Hi, and welcome back. Now we're going to move on to our next topic, and we're going to get an opportunity here to rediscover some things we probably know, but let's dive deeper into inflammatory bowel diseases, IBD. Remember, this is different than having irritable bowel syndrome, IBS, sometimes gets mixed up. But inflammatory bowel diseases, there's actually two different diseases that we focus on: ulcerative colitis, sometimes called UC, and Crohn's disease. And both are similar in the fact that it involves chronic inflammation of your GI tract. Other conditions can also present, or excuse me, both of these conditions can also present with other symptoms like bloody diarrhea, abdominal pain, and weight loss. So, what are the key differences then? With ulcerative colitis and Crohn's disease, I typically have students really focus on the pathophysiologic difference, starting with the anatomical locations. Now, primarily, ulcerative colitis is going to affect the colon and the rectum. And you're going to see a more continuous inflammation starting at the rectum. Whereas Crohn's disease can happen throughout any part of the GI tract. And often you're going to see skipped lesions where you have areas of normal tissue, and then you'll have inflamed areas, and then areas of normal tissue, and then possibly even more inflamed areas. And worsely, you might even see fistulas and abscesses as well. Again, ulcerative colitis typically causes continuous inflammation, and also Crohn's disease involves discontinuous inflammation and can happen throughout the GI tract. Now, let's consider some of the differences in treatments then. Take a minute to pause and think about how patients with ulcerative colitis and Crohn's disease are treated. Okay, there really is no cure, unfortunately, for Crohn's disease or ulcerative colitis. But what we try to do with our patients is try to manage their symptoms and reduce their flare ups. So, medications help to decrease the inflammation, improve symptoms, and we try to control this inflammation because our goal is to reduce the risk of tissue damage. And once there's tissue breakdown, we're at higher risk for other issues like malnutrition because we're not able to absorb nutrients. And especially are if you've been diagnosed with IBD, Crohn's or ulcerative colitis at a pediatric age, then you have a greater lifetime risk of complications because you are dealing with this disruption to your GI tract for a longer amount of time. And so, for some patients, medications are not enough, and you actually will need surgery. There's alternative treatments as well to help manage the pain and the discomfort that's associated with IBD, like acupuncture. We can even try probiotics. And there's other new clinical trials and therapies that I'm going to encourage you to investigate a little bit further. Won't be on the quiz, but I do want you to be aware of the medications. And now, with patients with Crohn's and ulcerative colitis, we are using anti-inflammatory agents, right? Because we want to reduce the flare-ups. And so corticosteroids are often prescribed. And unfortunately, we don't use corticosteroids for long term because of their increased side effect profile. So we try to limit the use of corticosteroids to symptom relief, not long term therapy. Excuse me. But now we have aminosalicylates. We have 5-ASAs, and they are going to help with this inflammatory response. Now, they will hopefully, in theory, decrease the tissue irritation that happens. And works specifically on your GI tract in areas where the disease is the most severe. Commonly, we use this to treat ulcerative colitis because we can target the colon specifically. However, if you have mild Crohn's, aminosalicylates can also be used as well. Now, we also have immune modulators, a newer type of medication than others. When you think of methotrexate, you may have heard that medication. That's a very common oral immunomodulator, and we use this for both Crohn's and ulcerative colitis. Again, we're trying to reduce inflammation, but here we're really targeting the patient's own immune system. And though we can target, it does happen really slowly. And so patients don't usually notice an immediate response. So during times where patients have acute flare ups, we need to combine these medications with other drugs that can work more effectively quickly. Biologics are also drugs that help, like monoclonal antibodies, that will bind to specific proteins in cells to interfere with the overall body's inflammatory pathway. They're effective for severe IBD, and these are one of the drugs that you can actually combine with other medications like immunomodulators. And we use these drugs actually not only for IBD, but we can use immunomodulators for rheumatoid arthritis, psoriasis, and other type of flare-up diseases. Of course, we can use antibiotics if that is a specific reason of why the Crohn's disease or the ulcerative colitis is being activated or exacerbated. And so, if there's tissue injury or possibly a perianal fistula or disease process, then we may use antibiotics. Remember when I said that diarrhea can be a part of the symptom process? Well, antidiarrheas can also help. If we use bulking agents, this will help to increase the muscle tone in the GI tract, reducing diarrhea. Think about antidiarrheals like loperamide. That's usually prescribed. And then there's other supplements, vitamins and minerals, and sometimes patients need nutritional supplementation because they're not able to absorb the full nutrients, like patients that do not have ulcerative colitis or Crohn's. Now, again, this is very general. There are other symptom management techniques and there's other medications out there, but to give you a broad sense of the disease processes, we'll start here. I'll see you in